Low back pain. So many people deal with it, and often it just sticks around becoming chronic low back pain.
That's right. It's incredibly common and frustratingly persistent for a lot of folks.
But then what happens when that chronic pain gets, well, tangled up with something called central sensitization?
Central sensitization. Yeah,
Yeah.
that's basically when your nervous system itself becomes amplified, sort of turns up the volume on pain signals.
Even without a clear ongoing tissue injury.
Exactly. It's often linked with conditions like fibromyalgia, maybe widespread pain, but also things like, sleep issues, fatigue, just this general feeling of the system being on high alert.
Okay, so if you're already dealing with chronic low back pain, adding that layer, that sounds like it makes things a whole lot tougher.
It really does. And historically, we knew central sensitization could make pain feel worse, subjectively. But it wasn't always crystal clear how much it directly affected someone's physical ability, how they actually move and function.
Right. So that's precisely what we're diving into today. We've got this study published in the Journal of Bodywork and Movement Therapies, and it looked specifically at people with chronic low back pain to see if those who screened higher for central sensitization risk, did they actually perform differently on physical fitness tests compared to those with lower risk?
Yeah, that's the core question. So our mission here is to really break down what this study found, to understand that connection or maybe lack of connection between the CS risk, physical ability, and, well, other factors like mood and quality of life in people with LBP.
And crucially, what does this mean for you, or maybe someone you know, navigating this kind of complex pain?
Exactly. What are the real-world takeaways?
Okay, let's unpack the study then.
All right. So the study itself was what we call cross-sectional, observational, descriptive.
Like a snapshot in time.
Precisely. Not tracking people over years, just looking at a group of patients at one specific moment and describing what they see.
And who was in this snapshot?
They had 85 patients, all with chronic low back pain, meaning pain for at least 3 months. Ages range from 26 to 63. So a decent adult spread.
Okay. And how did they figure out this central sensitization risk?
They used a specific tool, a questionnaire called the Central Sensitization Inventory, or CSI. It's designed to screen for people who might have those features of, an amplified nervous system. Based on the scores, they split the patients into 2 groups, lower risk and higher risk.
Got it. 2 groups based on CS risk.
Yeah.
And then they measure, well, it sounds like a lot more than just asking how much does it hurt.
Oh, definitely. They looked at a whole battery of things. Really important was measuring actual physical fitness and functional ability.
Using standardized tests, right? Objective measures.
Exactly. Not just asking how people feel they can move, but testing it. They used things like the 6-minute walking test.
Okay, how far can you walk in 6 minutes? Measures endurance.
Right. And timed up and go test the TG.
Ah, yeah. Stand up, walk, turn, sit down. Basic mobility.
Quick, but tells you a lot. Also, the sit-to-stand test.
How many times you can stand up from a chair? Lower body strength. Endurance.
Exactly. And really relevant for back pain trunk endurance test.
Sort of strength stuff. Holding positions.
Yeah. Testing the flexors, extensors, side bridge muscles. How long can you hold those positions?
Yeah.
Gives us insight into core stability endurance.
Okay, so that's the physical side, but they looked beyond that too.
Oh, yeah. They measured psychosocial factors using well-established questionnaires. Things like disability, how much the pain interferes with daily life. They used the Roland Morris Disability Questionnaire for that.
And what about fear? That fear of movement, kinesiophobia?
Yep, measured that too with the Fear Avoidance Beliefs Questionnaire, the FABQ, looking at beliefs about physical activity and work specifically.
And catastrophizing, those negative thoughts about pain.
Measured that as well, using the Pain Catastrophizing Scale, the PCS. It assesses, how much people might ruminate on, magnify, or feel helpless about their pain.
Wow, okay. And quality of life.
Covered that too, with the EQ5D3L questionnaire. It looks at 5 dimensions: mobility, self-care, usual activities, pain discomfort, and anxiety depression.
So a really broad look. Physical function, pain, disability, fear, thoughts, quality of life.
And they collected other info too. Age, gender, BMI, how long they'd had symptoms, medication use, other conditions like sleep problems or fibromyalgia, even self-reported physical activity levels. A very thorough picture.
All right, so they have these 2 groups, lower CS risk, higher CS risk, and all this data. Let's get to the results. What did they find? Were there things that were maybe surprisingly not that different between the groups?
Yes, actually. And that's quite interesting. Things like age, gender, BMI, they weren't significantly different. Even their self-reported general physical activity levels were similar between the groups.
So it wasn't just that the high CS group was older or less active overall based on what they said.
Not based on their self-report, no. And leg pain intensity wasn't significantly different either, nor was a measure called pressure pain threshold. Both groups consider themselves generally physically active.
Okay, so where did the differences show up?
Well, first, the group with the higher risk of central sensitization reported significantly higher low back pain intensity. That specific pain was worse.
Makes sense.
And this is key. Their symptoms have been going on for significantly longer.
Longer duration. That seems important.
It likely is. They also reported significantly more sleep problems and rated their general health as worse.
Okay.
And interestingly, patients who already had a diagnosis of fibromyalgia, which is often seen as like a prototype CS condition, they fell into this higher risk group.
I see.
And one more thing on this baseline stuff.
Yeah.
The higher risk group used significantly more anxiolytic and antidepressant medication.
Okay, so higher LBP intensity, longer duration, more sleep issues, worse general health, more mood-related meds, and includes the fibromyalgia folks. Now, the big question, how did they actually perform on those physical tests?
This is really where the study gets fascinating. The results were pretty clear. The group with the higher risk of central sensitization performed significantly worse on most of those objective physical tests.
Okay, so like the 6-minute walk test, they didn't walk as far.
Exactly. Covered shorter distances, lower walking endurance.
And the timed up and go? Slower?
Yep. Took significantly more time to complete that basic mobility task.
Sit to stand, fewer reps.
Fewer repetitions, indicating lower functional strength and endurance in the lower body.
And the core endurance tests? Same pattern.
Mostly, yes.
Yeah.
They showed lower endurance time for the trunk extensors, the back muscles, and for both the right and left side bridge tests. So weaker endurance in the back and side core muscles.
You said mostly. Was there an exception? I think I remember something about the front muscles.
You got it. Really interesting point.
Oh.
Trunk flexor endurance, the abdominals at the front, was not significantly different between the groups.
Huh. Why might that be?
Well, the researchers suggested a few possibilities. Maybe it's related to how people adapt their posture with chronic pain, perhaps relying more on or protecting those flexor muscles. Or it could be more complex changes in how muscles coordinate over time with pain. It's an intriguing detail.
That really is interesting. Okay, so measurable deficits in walking, mobility, lower body function, and most core endurance for the higher CS risk group. What about the psychosocial side? The fear, the catastrophizing, the disability?
Same clear pattern. The higher risk CS group scored significantly higher on all those measures.
So more disability.
Yes, significantly higher scores on the Roland-Morris, indicating greater disability impacting their daily lives.
More fear of movement.
Definitely. Higher kinesiophobia scores on the FABQ for both general physical activity and specifically related to work. More fear avoidance.
And more catastrophizing.
And much higher scores on the pain catastrophizing scale. So more of those negative, magnified, helpless thoughts surrounding their pain.
Wow. So they have more intense back pain, they perform worse physically, and they have higher levels of disability, fear, and negative thinking about the pain. What about overall quality of life?
Unsurprisingly, given everything else, it was significantly worse for the higher CS risk group. And importantly, it was worse across all 5 domains of that EQ5D3L questionnaire.
All 5, so mobility, self-care.
Yep. Mobility, self-care, usual activities, pain discomfort, which we knew was higher, and anxiety, depression. All significantly worse.
Okay, let's step back a bit. Taking all these findings together, what's the big picture message from this study?
I think the core message is really quite powerful. It shows that having signs of higher central sensitization risk in chronic low back pain isn't just about the pain feeling worse or maybe being more widespread. It's actually tied to concrete, measurable reductions in physical performance, how you can walk, move, use your core, and a significantly poorer overall quality of life.
So it really pushes back on the idea that CS is just about pain perception.
Exactly. It suggests the effects are broader, impacting tangible function. It really highlights that biopsychosocial model we often talk about.
Right. It seems like a perfect illustration. It's not just the back structures, it's the brain, the nerves, the thoughts, the fears, the function, all interacting.
Absolutely. This study strongly supports that model. It shows how these psychological factors, the kinesiophobia, the catastrophizing, the mood issues, all higher in the CS risk group, aren't just side effects. They seem to actively interact with and influence physical function.
So maybe it's not that CS directly makes your muscles weak, but the whole package? The amplified pain, the fear of moving, the negative focus leads to performing worse on tests.
That's a very plausible interpretation based on these findings. The lower endurance, the slower TU time, the fewer sit-to-stands. These limitations are happening in someone whose pain system is on high alert, who's more afraid to move because of pain, and who has more distressing thoughts about it.
Yeah.
It aligns really well with the fear avoidance model, too. Fear leads to avoidance, which leads to reduced activity and potentially deconditioning or loss of function over time.
And the lower quality of life scores just kind of reflect that overall impact on daily living.
Precisely. It captures the functional and emotional consequences of this whole picture.
Okay, so let's talk clinical relevance. Why does this matter in the real world for someone with LBP or for the therapist or doctor treating them?
It's hugely relevant. This study helps clinicians understand that when they encounter a patient with chronic LBP who also shows signs of higher CS risk, maybe through that CSI screening, or just clinically observing widespread sensitivity, poor sleep, high distress, they should anticipate a more complex situation.
More than just a bad back.
Much more. They're likely dealing with measurable functional deficits, significant psychological factors tied to the pain experience, and a reduced quality of life overall. It flags that this patient might need a different kind of approach.
Meaning treatment probably needs to go beyond just, say, exercises for the back muscles or manual therapy.
Exactly. It really underlines the need for a comprehensive, multifaceted approach. For these patients, just targeting the peripheral tissues in the back might not be enough. Treatment really needs to integrate strategies addressing the psychological factors, the fear, the catastrophizing, and maybe environmental factors too, alongside appropriate physical interventions.
It's about treating the whole person experiencing the pain, not just the painful body part.
That sums it up perfectly. You have to consider the central nervous system changes, the thoughts, the emotions, the behaviors, and the physical capacity.
So this deep dive really makes it clear. For people with chronic low back pain, this risk of central sensitization isn't some abstract concept about nerves. It's tied to real-world differences in how they can move, their core function, their whole psychological relationship with pain and activity, and ultimately their quality of life.
It makes that mind-body connection incredibly tangible, doesn't it? Especially in this group.
It really does, and it leaves us with a pretty important thought, doesn't it? Considering just how strongly the central sensitization risk is linked with not just more pain, but also less physical function and more psychological burden. What does this study really tell us about the need for healthcare approaches for chronic low back pain that genuinely integrate the mind and the body, going beyond just the physical? Something for you to mull over.